Okay. So here we have a case of a male, 44 years old, bilateral keratoconus, high myopia, amblyopia on one side, and wearing contact lenses. In 2016, there was a major scarring apically, so the visual acuity deteriorated, so we decided to perform DOLC, decimate DOLC in particular, because we couldn't complete the bubble technique, but during the procedure there was a small perforation, so in a double chamber, and this double chamber after a few days that was managed by injecting an air bubble that disappeared. So after a few days from the treatment, at the interface these lesions appeared. You may see them quite clearly, I hope, here. So at the interface, we got these confluent, small and whitish lesions. So at this point, the first question emerges. What do you think? Should we suspect an inflammation of the interface, a bacterial keratitis, fungal keratitis, or protozoal keratitis? Or should we have, of course, ruled out debris or reepithelialization because there weren't the typical clinical features to suspect it? So these were the four options. What do you think? So let's say that you think of an inflammation or fungal keratitis. These two answers are were given by the majority of the audience. Okay, so let's move on. What test should we or procedure would we perform? Corneal confocal microscopy, aware of the problems of reaching the interface when such a procedure is underway, or corneal interface scraping, and then a diagnostic exam with the OCT of the anterior segment to see what we can learn from it. So, confocal microscopy, okay, we agree, and many of you think that it might also be useful, an OCT of the anterior segment, which actually is what we did. So we continue. So the scraping, as we expected, was negative, whereas the confocal microscopy showed these hyphae-like lesions that may be interpreted as lesions due to the presence of a fungus or a yeast. So this confocal microscopy was seen by many experts, and no one gave a definite answer in favor of one or the other assumption. So here we might suspect fungal keratitis. This was our suspicion. So what to do now? Directly keratoplasty, and according to the literature, LD intersections of the interface by fungus can be resolved by removing the tissue, or we can change the lamellar graft or interface washing, or medical treatment plus an interface washing once the medical treatment has already been initiated. I would say that the last option got the majority of votes. So let us see what treatment, that is to say antibiotics and antifungals topically, or systemic antifungal therapy, antifungal eye drops, or antifungal and systemic and antibiotics topically. So here again, the association, the combination of a general therapy plus or including antibiotics. So we've asked the eye bank whether there might have been a decontamination of the storage medium. The answer was no. So we started with topical fortified antibiotic eye drops plus voriconazole eye drops 1% plus tablets 200 milligram twice a day. This was the treatment we had available. In the meantime, we ordered natamycin, which in Italy isn't readily available. So after 2 weeks, the clinical picture had deteriorated, and the patient did not tolerate voriconazole, generally speaking. So we have moved to hydroconazole, and so topical disinfectant, and plus natamycin hourly added. And then 3 weeks after, there was no improvement. So we decided to perform a washing, and we were very worried in raising the flap because we knew that there had been a small perforation. So we washed with natamycin. During the procedure, we have entirely raised the flap. We turned it, and then we actually wetted in riboflavin 5%, and then we have repeated the washing with natamycin, and we have replaced our flap. So it was a cross-linking from the stromal deep layer, where probably most likely there was an infection. This was our procedure. Then we continued with the eye drops, natamycin plus amoxifloxacin eye drops. So the culture examination of the biopsy, intra-op biopsy, gave Candida albicans. After 1 month, so this is how the DOLC appeared. So the picture had resolved, the cornea was clear again, and to this date, even at the confocal microscopy, we don't see the lesions that we had identified as hyphae-like lesions, and this is the final clinical picture of the patient. You see astigmatism 7/10 with contact lenses, with the myopia that had remained the pre-op one, and so a clear graft, and after all, a number of issues that we succeeded in preventing. Thank you so much.